Thank you everyone for being here. As Pam kindly introduced me, I'm Andrea Rodriguez-Villafane. I'm presenting from Baltimore, Maryland, and I hope that everyone gets as passionate as I am about my master's essay topic, which is the process and outcomes of the Hard to Reach study in Uganda. So HIV and AIDS have unfortunately cost the lives of millions of people around the world. There is a global effort to end the HIV and AIDS epidemic now by 2030. And currently, individuals in the African continent have been the most burdened, with the most cases being in Eastern and Southern Africa. There is a need to scale up HIV interventions, and understand how these interventions impact populations. And by interventions, I mean like HIV testing, antiretroviral therapy, preventive HIV coverage. And the Rakai Health Sciences Program, or RHSP, does exactly that. This organization is the one I collaborated with during my field placement in Uganda, and they provide HIV services, and they also run the Rakai Community Cohort Study, or RCCS, which is a longitudinal HIV surveillance study that has been going on since 1994. And together, the RHSP and RCCS has played an immense role in HIV surveillance and HIV care in this region in central Uganda. But as in life, there is a challenge, which is that not everyone that is eligible to participate in RCCS study actually participates in it. In fact, last RCCS round, only of the eligible people, only 62% of them participated. And so this brings two issues. Oh wait, I forgot to mention that of the people who are eligible but do not participate in RCCS, most of them, what happens is that when the research team is trying to survey them, they are not around because they are either away at work or away at school. And then this situation of people non-participating because they have high mobility brings two issues. The first issue is that it might have negative effects on HIV surveillance efforts. Why? Because what if these people who do not participate in RCCS and have high mobility, they have, for example, higher HIV incidence than the people who do participate in RCCS, just like we would expect from the literature. Then this might result in bias in the RCCS HIV service coverage and incidence estimates. The other issue that this non-participation causes is that it also hinders HIV elimination efforts, because when individuals participate in RCCS, they are given HIV testing and referred to other HIV services. So by these highly mobile individuals not participating in RCCS, they are not benefiting from those HIV services. So clearly, the RCCS study and the RHSP services do not reach all intended population, mostly very highly mobile individuals that we consider hard to reach populations or hard to reach individuals because they are literally hard to reach. And thus was born the Hard to Reach study. The aim of the Hard to Reach study was to try to use different mechanisms to track and survey these individuals that were identified as hard to reach from the last RCCS survey round. And then my personal role in this project was to then try to examine this process of tracking individuals with different mechanisms and these hard to reach individuals and evaluate their outcomes. A little bit about the methods. This whole project started by having the research team collect contact and location information of these hard-to-reach individuals. This happened by the team asking family members of these hard-to-reach individuals, like the phone numbers or the addresses uh, of the hard-to-reach individuals. And then the team proceeded to try to attempt to track the hard-to-reach individuals. And the tracking was done with many different mechanisms. Like some of them were like calling via phone or driving to do in-person visits to the location that was expected to find the hard-to-reach individuals, and other mechanisms. And finally, when I come in, I had to evaluate all the data that was collected during the tracking process, like the attempt numbers, the mechanisms, and then the outcomes, and analyze it. So for my results, the first thing I did was try to understand what the outcome of all those hard to reach individuals that were tracked were, and categorize them. Of the 1,054 hard to reach individuals that were tracked, we see that 86% of them were enrolled. And that is incredible because they are hard to reach individuals. They are highly mobile. So this was an extremely amazing effort from the team to be able to enroll. Oh, and by enroll, I mean administer the survey and do the HIV testing and referrals. But it's an amazing outcome. Then we saw that about 12% of the individuals tracked refused to participate in the hard to reach study, to get enrolled in it. And reasons for refusal varied. It could be because they were just not interested in the study, they were too busy, among other reasons. About 1.15% of the individuals had outmigrated, and this means that they had moved out of their community. And once they moved out of the community, they're no longer eligible for this hard to reach study. About 1% of the individuals were unreachable. And what does this mean? It means that even though the research team, they had the phone number and the address, maybe the phone number, it was a wrong number, but the address, they couldn't find the person. So there was no way to find the person, or maybe they did know the location of the person, but it was so far away that they could not go there to enroll them. And about 0.38% of people were ill-disabled, which meant that they were physically incapable of being enrolled and do the survey. And fortunately, no one had passed away in this sample. Those were the outcomes. I also wanted to know about the number of attempts that were needed to do that were done during this tracking process by mechanisms. Here in this figure, we have the outcomes on the y-axis and the x-axis, and then the average number of attempts on the y-axis. And if we only focus on the individuals that were enrolled after the tracking process, we see that for our team, it took an average of like 4 attempts, tracking attempts, in order to enroll the individuals. And I could also break down this average number of attempts by the mechanisms that were used. And so it seems that for our team, there needed an average of 2.17 calls to the hard to reach individuals to enroll them, an average of 0.05 calls to the individual's contact, an average of 0.21 calls to family members of the hard to reach individuals, an average of 0.05 callbacks from the hard to reach individual to the team, an average of 0.01 a callback from the family members of the hard to reach individual to the team, an average of 1.18 in-person visits to the hard to reach individuals, and an average of 0.38 visits from the individual to an RCCS site, which is a clinic. We also, I was also very curious to know because the participants, the hard-to-reach individuals, were offered an option of the where they would be enrolled. They could either go to an RCC site, which is a clinic, to get enrolled, or they also have the option that the team go and visit them, go to them at their location, be it like their workplace or their house. And the results showed that 66% of the hard to reach individuals chose to be enrolled at their location, compared to 34% who chose to be enrolled at a RCCS clinic. And this could be because of many reasons, maybe because of transportation, privacy, waiting time. And all of this information brings me to the conclusions, which are that, first of all, tracking was very effective in our research project to reach hard to reach individuals. It did need a lot more effort because there needed to be so much like driving to the individual's locations, do a lot of phone calls, and we needed like multiple attempts, more than 4 attempts on average to enroll hard to reach individuals. There was also a need to use multiple mechanisms, in our case, mainly phone calls and in-person visits. And it was very useful to provide options to the hard-to-reach individuals. So for where they wanted to be enrolled at what location, where their location or clinic. And I think all this information is extremely important because if there's like an HIV study in the future or an HIV program that wants to do tracking and reach hard to reach individuals that are highly mobile, they should take all of these things into consideration. And this was just like a preview of my results of my master's essay. If you want like the whole thing, you can totally read it. So I'll end up just by saying thank you to my reader, Dr. Engelwicks, my PI, Dr. Tang, people from the Hard to Reach team, my supervisor, Josephine, and so many others, obviously the study participants. And with that, I'll take any questions.
I know you were on site for your field placement, Andrea, and I guess I'm just curious to know, like, what was like your favorite part of that, and like, what were some difficulties you faced?
I think so. My favorite part of that was, first of all, discovering that I enjoyed using data and like doing quantitative research because it was good to find something I enjoyed in life, and also just the amazing like relationships that I developed with people in my project, especially my like on-site supervisor. She was so wonderful. And I think then the challenges that I had was that it was very uncomfortable knowing that the team was so busy. They had so many things to do. And then I was there like constantly like asking for their time, asking for their help, and and trying to find that balance of like advocating for myself, but at the same time like not being annoying, like knowing that I'm an outsider, like going in to their day to day. So that was it. But in general, I appreciate the experience so much, and I'm so grateful for all of them.
Wonderful. Thank you, Andrea. Great presentation. A good way to start us off. So I think we'll move right along. We're running a little late. So our next presenter is Fouzia Khan. Fouzia came to us with a master's degree in public health in international health from the University of Liverpool. Her essay topic is Vaginal Microbiome and Risk of Preterm Birth in HIV Positive Women, a scoping review.
Thank you so much, Pam, for that introduction. So I will be presenting on vaginal microbiome and the risk of preterm birth in HIV positive women, which is a scoping review. A little bit of the overview. I'll talk about introduction, what is the problem, the rationale before conducting the scoping review, the objective, methodology, what were the results, conclusion, limitations, and what are the future recommendations. So these are the few keywords that I have used during my presentation, and I'm sure all of you are very much familiar with these terms, but I will still like to go through them. PTB, the preterm birth, HIV, human immunodeficiency virus, ART, antiretroviral therapy, PW, LWH, pregnant women living with HIV, HUPW, HIV, uninfected pregnant women. CST is the community state type of microbiomes, the classification of microbiome in different categories. GA is the gestational age, and LBW is the low birth weight. As you all know, preterm birth is defined as the babies who are born alive before 37 weeks of pregnancy are completed, and this is a WHO definition that is widely used across the globe. 15 million babies are born preterm every year, which accounts for 10% of the births worldwide, and pregnant women with untreated HIV have a higher risk of preterm birth, 3 to 4 times higher than those who are on ART. In some parts of Africa, maternal HIV infection complicates as many as 1 in 4 pregnancies and increases the risk of preterm birth by 50%. Microbiome play a very important role in the reproductive health, and lactobacilli is the most important that helps in holding up the pregnancy and keeping the vaginal pH acidic and prevent STIs. So any disruption in the normal vaginal flora can lead to bacterial vaginosis that is associated with twice the risk of maternal infection, miscarriage, low birth weight, and preterm birth. So this is a little bit pictorial depiction of how lactobacilli protect the mucosal lining. Microbiomes are present in everywhere in the body wherever there is mucosa. So there are as many microbiome as the number of cells in the body. But in vagina specifically, they promote the integrity of the epithelium by production of active components like lactic acid and hydrogen peroxide, and they also help in modulating the immune response. The cervicovaginal microbiomes are first categorized by Ravel et al. In 2010 in 5 different groups. And to identify them, there were 3 community sequencing methods that were used, and they are now currently being used instead of traditional methods. One is the shotgun metagenomic methods. Another is amplicon sequencing, which is also marker gene sequencing. And third is metagenomic metatranscriptomic sequencing. Apologies. So this is, again, a pictorial depiction of how these tests are conducted in the lab, the genomic analysis and the culturomics. I'm not going to go into the details of that. So what exactly is the problem? There is some research that has examined the role of immunological factors and vaginal microbiomes in spontaneous preterm birth, but there is very little information comparing these variables according to the maternal HIV status. And despite the advent of effective ART, which enables immune reconstitution and reduces the rate of mother-to-child transmission of HIV to less than 1%, the rate of preterm birth has still not declined. So the rationale to conduct the scoping review was to synthesize and map this literature that can help us understand the role of vaginal microbiomes in microbiome in preterm birth in HIV positive women, to identify potential interventions and area for future research, and to help guide clinical practice and policy development. I had few objectives. I initially wanted to conduct a systematic review, but because we were unable to find many research papers, so we ended up doing a scoping review. The objectives were currently to know the currently known types of and role of vaginal microbiomes in preterm birth among HIV positive pregnant women. Are there any differences in vaginal microbiota composition of pregnant women living with HIV, and if they influence the local inflammation and subsequent risk? Is there any difference between the composition of vaginal microbiomes and pregnancy outcome in pregnant women with HIV, irrespective of their ART status? And what are the gaps in knowledge and inconsistencies in the literature on this topic, which can guide future research studies? So to conduct this scoping review, I searched Google Scholar, PubMed, Scopus, Embas, and Prospero, which is an international database for prospectively registered systematic reviews in health and social care. I wanted to see if there is any ongoing systematic review or meta-analysis or any scoping review that has been registered, but there wasn't any study. So these are the search terms and the concept notes that I came up with the help of a librarian. I'm extremely grateful to the librarian, Donna, who helped me in building these search terms and narrowing down all the papers. The search strategy for inclusion criteria, original prospective cohort and observational studies with quantitative data regarding maternal demography and pregnancy outcome were included. Studies that have included pregnant women with HIV on ART or have started ART during pregnancy. Studies that have used modern DNA sequencing technology to study the microbiome, and all study settings were eligible for the inclusion. Studies who were the narrative reviews or literature reviews, simple reviews, or the qualitative studies were excluded from the criteria, and studies with sampling after onset of labor. Since we were only interested to see the effect of pregnancy on microbiome, we excluded those that included the women with onset of labor. And studies that were investigating specific pathogen, and studies that used Nugent scoring instead of the latest sequences. So this is the Prisma flow chart that I made with the help of Covidence. And when I searched Google Scholar, there were like 9,880 articles, and I'm like, oh. Then we came up with the search terms with the help of the librarian, and we ended up with only 3 studies that fulfilled the criteria. So these 3 studies were conducted in UK, Zambia, and Zimbabwe. In the UK study, there were 75 total pregnancies. In Zambia, there were 221 total pregnancies. In Zimbabwe, there were 356 total pregnancies. In all the studies, there were some HIV positive. In UK, there were 53. In Zambia, there were 85. In Zimbabwe, there were 42. So they were not proportionate number of HIV and non-HIV pregnant women. Median ages were also different in all these studies. Only one study, which was conducted in UK, mentioned about the ethnicity, and majority of them were 77. But in Zambia and Zimbabwe, since these are the African countries, I automatically assume that the study population was Black population. In the UK study, there were 12% pregnancies that ended up in preterm birth, and all of them were HIV positive. In Zambia study, there were 13% that ended up in preterm birth, again in HIV positive. And in Zambia, there were 8% preterm birth overall, with 11% in HIV positive and 6.8% in HIV negative. All these 3 studies have used the latest technology of gene sequencing, the amplicon sequencing, which whole shotgun, and 16S ribosomal nuclei. So they classified the microbiome in 3 different ways. One categorized in 7 groups, one categorized in 6 groups, and one categorized in 7 groups. And they all had different criteria. So there was a lot of heterogeneity in classifying the microbiome. For the results, so all studies found that the vaginal microbiome were more diverse in pregnant women living with HIV as compared to women who were uninfected by HIV. And there was a low prevalence. So when they categorize a microbiome, the Lactobacilli crispastus had a low prevalence than as compared to Lactobacillus inner. The Lactobacillus crispastus had positive association with the gestational age at delivery. They calculated the they conducted a Shannon diversity index that was highest in HIV positive as compared to HIV negative. And the multivariate analysis in the Zimbabwe study showed significant association between HIV and the diverse community state types of microbiomes. All preterm birth in UK study occurred in women with high diversity microbiome. Similarly, the same results were in Zambia, and the same results were seen in the Zimbabwe study. All 3 studies confirmed high prevalence and vaginal microbial diversity among the pregnant women living with HIV. They also found a correlation between vaginal microbiomes and inflammatory markers that cause spontaneous preterm birth. However, strong correlations cannot be made due to heterogeneity among the sample population of all these 3 studies. The study conducted by Schott et al. In the UK found the presence of Lactobacillus crispastus, which is not associated with preterm birth, but higher presence of anaerobic Prevotella, Acinathia, and I'm not going to pronounce all of them, but associated with spontaneous preterm birth. And pregnant women who were on ART had less chances of preterm birth. And these results were in contrast with the study that was conducted in Zimbabwe, who did not find any association between vaginal microbiomes, vaginal cytokines, and preterm birth. So this disparity could be explained in part by variation in the study design, gestational age, sampling technique, and the sampling technique. So in conclusion, it is hard to establish an association between vaginal microbiome and adverse pregnancy outcome in HIV positive women. It remains unclear if microbial diversity in pregnant women living with HIV or disruption in normal vaginal microbiota due to increased vaginal inflammatory marker can lead to preterm birth. However, it is certain that vaginal microbiome in women with HIV are markedly different from women without HIV. There are several limitations in all of these studies and overall in the scoping review. The inclusion of studies with heterogeneity in study type, population, and vaginal microbiome classification is one of the main limitations. The gestational age at which the vaginal samples were collected were not clearly defined in any of the studies. This makes it difficult to draw strong conclusion on the association between vaginal microbiome, HIV, and preterm birth. Additionally, underlying risk factors were not well defined in any of the study and were not incorporated in the analysis. There was lack of data on collection of recent antibiotic use that can change microbiome in the vagina. So my recommendations are that there is a need to construct universal vaginal microbial classification to create uniformity among future research studies, and future research with robust research methodologies, diverse participants' characteristics, and bigger sample size are required to identify predictive and preventive factors of preterm birth, especially in women living with HIV. Thank you. So this is my PI, Dr. Anna Paul, with whom I am currently working on the same project in Johns Hopkins Hospital. Thank you to Dr. Saifuddin Ahmed, who was my first reader, my supervisor, Dr. Mary Catherine, and my babies. They are not babies anymore, but I love this picture. And special thanks to Pam for being a wonderful human being and mentor. My department, my cohort, my friends, and me myself for being sane.
Thank you, Fouzia.
Thank you so
for
much.
the personal shout out, and thank you for a wonderful presentation.
Thanks, Fouzia, for that presentation. It was really good. I was just wondering, have you considered any of the other factors that can change vaginal microbiomes other than infections like HIV?
Yes, there are actually several factors that can change the vaginal microbiome. And one is like having sex in the last 24 hours, douching, obesity, some underlying diseases like diabetes mellitus or hypertension. So these are some of the risk factors that have been stated in the literature.
Yeah, I just had a quick question, Fouzia. I think at some point you mentioned something called the Shannon Diversity Index. Can you just quickly explain what that is, please?
So Shannon Diversity Index is a quantitative analysis which is conducted by the scientists, and they create the heat maps to see the diversity and evenness and richness of all the microbiome that are present in that specific sample.
Our next presenter is Lana Aldos. Lana came to us from Cornell University with a Bachelor of Science in Biology and Society. The title of her master's essay is Evaluation of the Quality of Online Asynchronous Humanitarian Health Education. Lana, it's all yours.
Hi, everyone. My name is Lana. Today, I'm going to be talking about my research proposal on the evaluation of quality education for humanitarian health professionals. Just a quick run through of the agenda. First, I'll provide a brief introduction of what are humanitarian emergencies and how quality health and quality health educations apply to humanitarian emergencies. I will briefly describe my statement of research questions, methodology, and timeline. And finally, I will go over the limitations and key takeaways. So humanitarian emergencies have become an increasingly prevalent topic in our world. recently with the earthquake in Turkey, and there's also the Ukraine war. And it's affecting a significant portion of our global population. And so the statistics show that approximately 1% of the world population have been affected by humanitarian emergencies in the past 20 years. These emergencies have had consequences, including increased mortality rates, mass displacement, and the rise in homelessness. And the outcomes have created immense challenges for individuals, communities, and societies. And this is true not only for refugees and humanitarian immigrants, but for refugee host countries as well. One particular area of concern is the limited quality of health services available in humanitarian settings. In these emergencies, there's a large strain on health systems, often leading to inadequate access to quality care and exacerbating health outcomes. And I hope to address this in this evaluation proposal by highlighting the role of quality education in the delivery of quality health. So what is quality health and how do we measure it? I've designed my entire practicum experience to try to explore each one of these quality health indicators and get a comprehensive understanding of what is quality health. So I've created this list of common indicators based on previously published literature and also result of needs assessments and interviews with humanitarian professionals. The first one is the primary focus of my proposal, which is education and training of healthcare professionals. By examining and improving the quality of education and training programs, we can enhance the preparedness, competency, and effectiveness of healthcare practitioners in humanitarian settings. Another key indicator is improved access to healthcare services. This means ensuring that healthcare professionals are equipped with the necessary skills and knowledge to provide timely and quality care. An example of this is my work with the Maryland State Health Department, where I helped create a standardized screening manuals for refugees and humanitarian immigrants, which helped healthcare professionals in their skills and knowledge to provide quality care. The third indicator is the effectiveness and efficiency of health interventions. Healthcare professionals should be trained to implement evidence-based practices and achieve positive health outcomes in the limited resource setting and the challenging environments that they work in. And the fourth one is on equitable distribution of resources. Quality also means that refugees, humanitarian immigrants are receiving equitable care, and that resources provided to them do not vary in quality compared to host country population. Finally, healthcare facilities must provide a safe and secure environment for both patients and healthcare professionals, which includes protocols for infection prevention and control, disaster preparedness, and the implementation of safety measures. One of the primary goals of quality humanitarian education is to improve the quality of health in humanitarian emergencies, which means that we should be equipping healthcare professionals with the essential skills and knowledge required to address the diverse health needs of humanitarian populations, including the trainings in emergency response, cultural competency, trauma care, and other relevant areas to humanitarian emergencies. By focusing on quality humanitarian education, we can also ensure that humanitarian professionals have the expertise to deliver appropriate and effective healthcare services. And finally, quality humanitarian education fosters a culture of continuous learning and improvement among humanitarian professionals, encouraging ongoing professional development, knowledge sharing, and the adoption of best practices. Overall, this would improve the quality of care provided to humanitarian population. In today's digital age, everyone is familiar with asynchronous online learning, and the majority of humanitarian professionals have used at some point or currently use AOL, asynchronous online learning to access humanitarian education. It has become an increasingly valuable tool for professional development, including humanitarian aid professionals. And I wanted to touch down on the most significant benefits of AOL that apply to humanitarian professionals today. The first one being cost effectiveness. Online courses and training programs are often affordable compared to traditional in-person trainings, which reduces the financial burden on individuals and organizations in the humanitarian field, specifically since the majority of work is done by nonprofit organizations, and a lot of these humanitarian professionals have limited financial resources to access educational materials. Secondly, AOL offers the advantage of efficiency. Professionals can access learning materials and participate in training programs at their own pace and convenience, eliminating the need to travel and accommodating their busy schedules. And the third benefits is that AOL provides an adaptive learning experience for humanitarian aid professionals. Online platforms often incorporate interactive elements such as quizzes, simulations, case studies that allow humanitarian professionals to apply their knowledge in practical scenarios, real-world experiences. And finally, and I think it's most importantly, is that humanitarian professionals often work in conflict regions, war zones, humanitarian regions affected by natural disasters, and they face challenges in accessing traditional training opportunities. But with AOL, they can access educational resources and training programs from anywhere with an internet connection, which sometimes can be challenging, but it still reduces the burden of accessing material. And this ensures that they have equal opportunities to professional development. There are two main research questions in this proposal. First being, what is the quality of current humanitarian health courses? And second, how can AOL improve accessible training opportunities for humanitarian professionals to overall improve the crisis response to the health crisis response? So the goal of this evaluation is to assess the quality of humanitarian health education, specifically, like I said, in the context of health education, by utilizing a systematic approach to identify areas for course improvement. The first step in this evaluation is pilot testing a course quality rubric, which I have already developed with the Harvard Humanitarian Initiative to test on courses that are not health specific. This rubric has been designed to assess the quality of humanitarian health courses and will be a guiding framework for the evaluation process. The second step is to rate the quality of humanitarian health courses using this rubric, which will involve systematically analyzing course content, learning objective, instructional design, engagement strategies, and assessment methods. And finally, after the pilot test and the rating of online humanitarian health courses, we can develop a health-specific humanitarian quality rubric to only evaluate the quality of education for health courses. This would also provide a standardized framework for future evaluations for organizations to evaluate their own quality of education. And in this evaluation, we've also identified two specific focus areas for the methodology, which shed light on critical aspects of overall quality of education. The first one is that course design is a crucial aspect of evaluating the quality of online AOL courses. We will examine areas such as the presence of clear learning objectives, instructional design strategies, and the adequacy of assessment methods, which will help us assess how well the courses align with best practices and effectively facilitate learning outcomes. The learning experience is also a critical factor in determining the effectiveness of online of AOL education. We will also assess aspects related to learner engagement, technology usage, feedback mechanisms, and course support. I've included screenshots of the first part of this course evaluation rubric that will be pilot testing. This was designed based on, like I said, best practices in the literature that has already examined what are the key indicators that should be included in evaluation tools, as well as the web accessibility, WACG, the Web Accessibility Content Guidelines, which focus on accessibility for education. The first part of this rubric will focus on technology, and then it'll be assessment, navigation, and finally navigation of education. And I also wanted to note that this has not been done before. A lot of the course evaluations that are out in the research literature have focused on education that's not very humanitarian specific. And so having this disparity in evaluations in the literature is really what made me want to study this topic. A quick overview of the timeline. In August, we'll begin trainings of evaluators on how to use this rubric. And then we will start a data registry of all the of selected courses, health courses in the humanitarian field. And we will start the data collection on publicly available information on these courses. And then we'll pilot test the course quality rubric on the courses in this registry from January to March. And then in April, we'll be to May, we'll be doing the data analysis, and in June, the final report of findings and dissemination of results. We hope that this rubric, health-specific rubric, can allow nonprofit organizations, educational organizations like Disaster Ready to evaluate the quality of their own humanitarian education and improve it in the long run. A few limitations is that this evaluation is specific to English spoken courses and online asynchronous courses, which potentially limits the validity of the findings to in-person courses, for example, or synchronous online courses. The second limitation is that the sample size of available courses may not be representative of all the available web-based courses. We've only included the courses available on the most common utilized platforms, educational platforms by humanitarian health professionals. All right, key takeaways is that one, this project can identify gaps in the quality of humanitarian health education. Through our evaluation, we have pinpointed areas where improvements are needed, such as clear learning objectives, inadequate assessment methods, and limited learner support. Identifying these gaps will allow us to address the shortcomings and enhance the quality of humanitarian health courses. When we improve the educational experiences of humanitarian health professionals, we can better equip them with the necessary knowledge and skills that they need to address the world's most pressing humanitarian health issues. And another key takeaway from this project is that the development of a tailored course quality evaluation rubric will be a standardized framework to assess the quality of humanitarian health education, and it would provide a comprehensive and structured approach to evaluating those courses. And finally, I wanted to thank my master's essay reader, Dr. Mary Catherine Augustine, for being very patient with me and always providing me feedback and advice on my essay, and my academic advisor, Dr. Pamela Donahue. In these past 2 years, she's probably my best friend at this point. And I really appreciate her patience and her feedback throughout this process. And the endless recommendation letter request that I've emailed. And also Roger Legrand, who is the educational designer at the Harvard Humanitarian Initiative, who helped me design the course quality rubric for humanitarian education. And finally, the POP-FAM community for the endless learning experiences that I've learned from everyone. Thank you.
Thank you, Lana. So Yoyo, it's you. So Yoyo Ding comes to us from our own Johns Hopkins University. She received a bachelor's degree in chemical and biomolecular engineering. So not surprisingly, Her master's essay is titled Lessons Learned Around Pediatric Home Equipment Decisions from Social Context to Technological Platforms. Yo-Yo, it's all yours.
Thank you, Pam, for the wonderful introduction.
You're good.
Perfect. Hi, everyone. My name is Yo-Yo, and I'm super excited to be here today to share with you my thesis, which focuses on pediatric home equipment decisions. And first, I'll quickly go over our agenda for the next 10 minutes. I will set the stage by describing the unmet needs faced by parents who make pediatric home equipment decisions. Then I will go over the methods I use to conduct a literature review. And for the bulk of the presentation, I will present my findings in 3 parts, describing the family experiences of decision-making, exploring the shared decision-making framework, and proposing several technologies that may address the family's unmet needs. And lastly, I will summarize the strengths and limitations of the literature. So let's get started. So previous research suggests that decisions to initiate at-home life-sustaining equipment can be particularly difficult for families. First, these decisions are usually made during a prolonged hospitalization, which is exhausting and associated with uncertain prognoses. And second, because at-home life-sustaining equipment is uncommon, few families have relevant previous life experiences. Thus, many families lack a comprehensive understanding of family life with such equipment at the time of decision. Lastly, at-home life-sustaining equipment requires constant monitoring and is particularly intensive for a family. The decision to opt for such equipment may have a wide-range impact on the entire family, including parent job loss and financial struggles. So the picture on the right here shows a common setup of home ventilation, and you can easily imagine how the family's life needed to adapt for not only the extensive amount of equipment involved, but also the 24/7 monitoring needed. Overall, a combination of these factors make the decision to initiate at-home life-sustaining equipment very distressing for families and sometimes leads to regret. And to better understand the family's needs and find potential strategies to address them, I conducted a literature review. In the first step, I conducted a broad literature search using the keywords shown here. Then the 795 articles found were screened according to the inclusion and exclusion criteria shown on the right. Here, many articles were excluded due to their sole focus on clinical indications and lack of potential parental perspectives. And lastly, I found 32 articles that met the inclusion criteria and were included in the review. So comparison across the literature reviewed 5 domains describing the family decision-making experience. Across studies, nearly all parents experienced intense emotional distress surrounding home equipment decisions because they perceived it as a signal for worsened prognoses. Some parents also experienced intense conflicts with their family members about whether it was right to extend the child's life with home medical equipment. Multiple papers also agreed that parents have unmet information needs when making the decision, particularly around how home medical equipment would affect the life of their family. Former decision makers wish they had been better informed about the difficulties of home nursing, difficulties of traveling with a child with life-sustaining home equipment, and the extensive level of at-home care needed. Soon after discharge, they were faced with the surprising challenge of obtaining insurance approval for adequate home nursing hours, finding nurses to fill these hours, and ensuring the quality of care provided. In terms of decision support, the literature showed that parents resort to a variety of resources, including the child's core medical team, palliative care providers, and social workers. However, they often receive conflicting message from different clinicians. Many families desire support from other parents who are experienced with using this equipment at home, but many did not have access to such inter-family communication. And lastly, in terms of alternative treatment options and decisional regret, the literature is limited to home ventilation or tracheostomy. Many parents remembered home ventilation as the only option, and across studies, about 25% to 75% of parents reported regret on the timing of the decision, feeling uninformed, and perceptions of inadequate medical care. And I just want to quickly share 2 quotes from parents to better showcase their unmet information needs at the time of decision. One mother shared in an interview, "It is pretty impossible to carry a baby, a ventilator, a tank, and whatever else with the feedings up and down the stairs. We made a lot of changes at home." And another mother shared, my husband's not working because we don't have a nurse. I really wish we had known how much. It is just a financial part, how much loss of income there might be. And while the ultimate decision lies in the hands of the parents, their experience with home medical equipment could be greatly improved by lowering uncertainty and the need for unexpected adjustments. And the shared decision-making model, or the SDM model, is the framework widely discussed in literature to facilitate family decision-making. It emphasized the extensive bilateral exchange of information. The providers share with the families the benefits, risks, the medical and social impacts of home equipment or alternative options, while parents provide insights about personal goals, values, and preferences. Then together, clinicians and caregivers determine a course of action under the SDM model. And recently, there has been an emergent interest in literature on how technological platforms could be used to aid the decision-making process for parents and realize the SDM model. One of them is the HomeVent tool, which includes 4 parts. First is a website describing the experiences of families who previously chose for or against home ventilation, which I will show more in detail in the next 2 slides. Second is a question prompt list to promote discussion within the family and with clinicians. Third is an in-depth family interview exploring the family's home life and values. And fourth, a structured meeting within the medical team to review treatment options in context of the family's home life, values, and goals. And so here is a snapshot of the HomeVent website. The tool was developed from 38 in-depth interviews with families who made a variety of decisions about home ventilation. The interview data was synthesized into 6 modules shown here, and then there's 12 sub-modules. Many sub-modules, such as balancing work with time and money, touch on important unmet information needs and address forecasting errors commonly faced by many parents. And the tool is presented in the form of a publicly available website that allows viewers to hear from 6 composite family stories, both in English and Spanish. And here shows an example website page, which presents contrasting perspectives side by side for each module. And by doing so, the tool systematically incorporates perspectives of families who chose for and against home ventilation, with the intention to create a balanced content. And the desire to connect with another family is a key unmet need of many parents facing the decision of at-home medical equipment. Actually, fewer than half of families discharged with tracheostomy had the opportunity to meet with another family. And in recent years, social media communities among caregivers have grown exponentially to fill the need. Common platforms used by parents include Facebook groups, Instagram, and Twitter. And these platforms bring families closer, fostering a sense of community identity with common experiences, struggles, support, and perspectives. Caregiver-only platforms also provide a unique opportunity for parents to seek advice that they're unable or unwilling to seek from healthcare providers. Interestingly, one study showed that while all English-speaking caregivers mentioned social media as a resource, none of the Spanish-speaking caregivers did. And this is likely due to lack of groups available in Spanish, inadequate access to internet, or cultural factors. And the last technology that I will share today is a cloud-based shared care plan, which serves to bring clinicians closer to each other. It is a comprehensive tool containing the child's medical history, medication list, appointments, goals of care, and action items that is developed in partnership with families. Nowadays, most care plans are still in paper format or documents scanned into the electronic medical record. As a result, they're difficult to modify in real time and not routinely used in everyday clinical settings. Therefore, a research group proposed the use of cloud-based care plans, which can be stored online and modified in real time to promote real-time information sharing among clinicians. The tool also organizes the content in a manner that addresses the user's specific needs. For example, a caregiver interface is shown on the top left, which includes care plans and developmental status. On the other hand, an interface preferred by complex care providers is shown on the bottom left, which includes medications and nursing notes. So overall, there is a high level agreement as to parents' decision-making process. It is intensely stressful, filled with unmet needs, and is a struggle to find adequate decision support. The literature also outlined comprehensive strategies to encourage effective information exchange between provider and family, family and family, as well as provider and provider. However, there are limitations in the available literature. First, despite a universal search strategy across different types of home equipment, most papers focus on home ventilation and tracheostomy. This is likely because home ventilation requires around-the-clock monitoring and is particularly intensive for caregivers, making it urgent matter to address. However, this also naturally skewed our analysis and revealed the need for studies that investigate the family's decision-making experience around home equipment other than ventilation. Secondly, most of the studies found used a retrospective lens in which insights were generated from interviews with previous decision makers. While such a design is useful, it is subject to recall bias, conformity bias, and selection bias. Thus, more studies with prospective designs are needed to confirm the key findings here. Lastly, we have also found that most proposed technologies have little to no actual evaluation of their effectiveness. In the future, research is needed to systematically evaluate the qualitative and quantitative outcomes of the interventions to identify practices that will best facilitate the family's decision-making process and informational need around pediatric home equipment. And that's all I have for today. And I just want to have a special shout out to Dr. Donahue and Dr. Voss, who's my PI in the Johns Hopkins Hospital, and many others who supported me along the way. Thank you.
Thank you, Yo-Yo. A very nice presentation. If you'll stop sharing your screen, we'll spend the time to take one question. Anybody have a question for Yo-Yo?
I have a comment. Can I?
Please, Fouzia.
This is such a difficult topic to discuss, but the way you have presented and the color combinations of this, they were calming, soothing, and very nice. Excellent. It was really nice. I have a question that when you were searching the literature, is it from like all the studies were only from US or only from US?
No, so actually there's studies from the US, Canada, and Australia. That's where most of the studies that I included for the literature review to be from.
Okay, and you said that there were no support groups for non-English speaking population. So when you were conducting your research, did you come across any paper who was published in Spanish, French, or because I know that in Canada, like half of the population speaks almost half French. So did you come across any paper? There might be some support groups out there for the non-English speaking groups population.
Yeah, definitely. I think that's a great comment. I'm actually from Canada.
Okay.
Yes. And yes, so there is actually the current data that I mentioned for the social media and how there's no support group for Spanish speaking families is largely from like interviews with families who enrolled in the studies. And I think the problem is in a lot of those studies, they only enrolled families who speak English. And I think that might be where the data is missing, but I'm sure there are some Spanish-speaking support groups out there as well.
So this is the gap in the research study that you, okay.
Exactly. So in one study, they did mention that they talked to a couple of Spanish-speaking families and they didn't mention social media. And I think that is where the data came from. But just in my understanding, the sample size of that Spanish-speaking population is significantly less than, across all the English-speaking studies.
And did you come across any study from the developing countries? I'm sure there might not be, but just any one single study?
No, actually, that's definitely something that should be happening. And I did not find any.
So, yeah, so another gap in the research.
Exactly.
Thank you, Yo-Yo. It was excellent.
Thank you, Fouzia.
Well, I think we're going to have to call it a day. Thank you to all of you who stuck with us because we went over time. And please congratulate all of our wonderful presenters today along with me. Well done, you guys. Well done.